Very much. Thank you for joining. As mentioned, I'm Jeff Haber. I'm a family doctor in North Toronto. Really excited to introduce these guidelines. I work on multiple guidelines committees, and I have to say this has been one of the most exciting. And I think because in primary care, these are so important for us because it's probably one of the most common things we do, as is diabetes, but we haven't had a hypertension guideline update and not one as good as these in many years. So let's go forward. These are my disclosures. These are Dr. Hundemer's disclosures. So we want to talk about an overview of hypertension treatment and control in Canada. What's going on? What have we been doing? What has changed? We want to talk about our new guideline approach, and you're going to see it's been quite a change. We want to unveil the new guidelines and dive into them, and dive into the algorithms and quite simple to help us all right after lunch. And we want to talk about what's coming. So in Canada, interesting. So in Canada, about 22%. So let's say 25% of Canadians have hypertension. It's globally it's higher, but it's interesting. We've achieved the rate that the World Health Organization said we should have in terms of control. And currently in Canada, about 61% of hypertensives are controlled. Interesting, that's not the same globally. If you look at global hypertension control rates, they run between 20 and 30%. So we're doing quite a good job in Canada, but certainly at 61%, we have a little ways to do even better. And this is just a projected hypothetical model. So if you look in Canada, we're at 60%. We globally are doing really, really well. But imagine if we had this aspirational scenario that we got to 70%. So just another 10% more were controlled. We could avert 52,000 deaths by 2040, which is only 15 years from now. So incredible and food for thought. So as well as we're doing, we certainly could do better. This is the Hypertension Canada 2020 guidelines, which we all paid a lot of attention to. They're busy. They were great, and it's what we had at the time. And they really stress a lot of the same things we stress in terms of automated office blood pressure monitoring, home monitoring, target levels. But a few things are going to show, we're going to show you today that things have changed in terms of targets. So the one thing that you most notice here is they are quite comprehensive, but there's a lot going on here. And I'm not going to go through these because we're going to introduce you to the new ones. In addition, the corollary to Hypertension 2020 is there's six different medication choices. You have the last one being a single pill combination that we're going to talk about. And on the right side, Hypertension Canada defines the high risk patient, which is important. That remains the same. But what's changed a lot is the thresholds and targets, and Greg's going to talk about that as we go on. But notice that they're saying for the moderate to high risk patient, um, they're saying the target if they're over 140 over 90, we get to targets of 140 over 90, and then if they're low risk or have no risk factors, we said in 2020 you didn't have to start treating till they were over 160. That has changed significantly, and we're going to show you that. I'm not going to spoil it for Greg, but I'm telling you it's changed. This is interesting, and the reason we've changed our approach is because of this. So, look back in 2007 to 2009, there was quite a disparity in the male-female treatment of hypertension. Um, Very, very interesting. And look at that disparity changed. Something happened in 2016, 17 where women dipped well below men. Then it came back in 2018, 19 in terms of treatment. Similarly, for control, it would make sense. Something happened in 2016, 17 where control rates seemed to dip, and it came back up in 2018, 19. But I want you to note where we were in 2007 at about 70% and where we are now at about 60%. So we've actually gone down in the last 18 years. So we're not sure. Why are these rates declining? Is it because there's a discordance in optimal therapeutic targets? You read multiple guidelines with different targets. It can be confusing. It's certainly complex. Maybe we haven't had adequate implementation strategies. How do we implement hypertension guidelines? Certainly, also, maybe we haven't been able to engage primary care as much as we should. And we know that the vast majority of hypertension treatment is in primary care offices, whether it's NPs, family doctors, nurses, pharmacists, and maybe there's been suboptimal engagement for multiple reasons of primary care professionals. And a lot of this has to do with the fact is there hasn't been any new hypertension medications in years, so there's really no industry support for education in hypertension. So, what we did, which is very exciting, and we're going to talk to you all about it, is we created these primary care hypertension guidelines in the last year, and there's going to be a public version. I'm going to let Greg talk about step 3 and 4 when he gets to his portion because there is more to come. And I think you're going to find this very useful and very practical, pragmatic for us in primary care. So these were published last Monday. Um, Greg and Remy Goupil were the co-chairs of the hypertension guidelines, and you see the rest of us. There's researchers, there's nurses, there's NPs, there's primary care physicians. Um, the interesting thing about these guidelines, and as I mentioned, I've worked on guidelines, it's very unique to have been published in so many places. So we're very proud of that, as you can see here. Why do we need primary care guidelines? I mean, I think you know by now from what I've been saying is we manage the vast majority of patients with hypertension. And the more complex a guideline, and we've seen this in every field, it leads to suboptimal uptake of the guidelines. If they're too complicated, primary care will ignore them, and there will be a therapeutic inertia. And I wonder, I mean, the 2020 guidelines were great, but I wonder if there was a lot going on and they were confusing and we didn't know how to truly adopt them. But there has been numerous requests, I'm going to show you in a second, to simplify this this diagnostic and management algorithm to make it simpler for primary care. So it's clear that we need to provide an evidence-based, pragmatic, practical, streamlined, and easy to implement recommendation that's tailored for us. So what we did, we created these guidelines, and every single step that we created, we were thinking of us, primary care professionals. So when we were hearing things that were tertiary or ivory tower like, we said, no, that's not practical for family medicine. These guidelines are created for us, for the NPs, for the nurses, for the pharmacists, and our patient partners. They're based on the Hearts framework, which was developed by the World Health Organization. And what they did is they looked at a framework creating very simplified treatment protocols that were very pragmatic, team-based, gave universal access to meds. And you'll see the algorithm they used, they wanted to simplify it. So what we did is we used the ADAPT process to adapt it to the current situation in Canada. In addition to reviewing hearts, we looked at AHA guidelines. We looked at ESC data. We also didn't ignore the work we had done, like that Hypertension Canada had done previously. We just adapted it for today. And after a peer review process, we completed these guidelines, which you're going to see imminently that were just published. Just to show you hearts, because it's so interesting. Actually, I'm going to go back for a sec. The QR code, it's an interesting read. So if any of you want to have a look at what was done in hearts, and we modeled the Canadian guidelines on that, have a look. It was a very interesting process, but I'll dive into it a little bit more now. So Hearts, back in 2001, Hearts said step one should be a diuretic or beta blocker. And as you can see, moving forward to 2009, that changed. So we got rid of the beta blocker. We'll talk a bit about that. And you can see step 1, 2, 3, and 4 in a very algorithmic approach. So you imagine this guideline's being thrown out to primary care physicians, and it's very simple. You follow step 1, step 2, step 3, and step 4. And that's actually what we did with the Canadian guidelines. You know, it's interesting because we have 2004 where 54% were controlled in the Hearts protocol, but going back to 2001, actually 44% were controlled. But move forward to 2010, we went from 44% control to 84% control. Unbelievable that we've doubled control rates. So it does work. This simple, pragmatic algorithm works to help control hypertension. So globally accepted, Hearts was implemented in over 40 countries. Over 17 million people are integrated in the program, and it's not rigid. As I show you, it gives you options, it gives you choices, and it's adapted to meet every single country's needs in terms of the medications that were chosen. And that's what we wanted to try and mimic in Canada for our primary care physicians. So, six pillars of Hearts, standardized treatment protocol and medication, as I just showed you, not only standardized, simple. We talked about blood pressure medicine and validated blood pressure devices, as we talk about in the Canadian guidelines. We talk about training and education of the practitioners and patients. We talk about data standardization and innovation in how the data is utilized. And that was utilized to create the heart protocol. We implemented research. Implementation of the research was used and the programs evaluated. We wanted to see, and we did see that big change from 44 to 84. And we want to talk about team-based care. And I know, and we talk about this in the guidelines, not everyone has access to team-based care, I understand, but we all have access to help if we need help. And we'll talk a bit more about that as we go along. So, target, as we mentioned, primary care providers, whether it be family docs, PAs, NPs, nurses, or pharmacists. And actually, it's intended as a framework that will manage over 90% of our hypertension cases. There are exceptions. I mean, there's those rare secondary hypertensions. They're not intended for women that are pregnant or trying to become pregnant. They're not intended for children. And obviously, you have to evaluate our guidelines on a case-by-case basis. So the guideline committee composition, we had family docs, we had pharmacists, we had an MP, we had hypertension specialists like Greg, we had methodologists with expertise in guideline development, and we had patient partners. And we believe it's always important to include patient partners with lived experience in any guideline that's being created. So how do we select our topics? In 2023, the Hypertension Congress had a consensus report, and they said there should be a streamlined, pragmatic, and evidence-based hypertension guideline specifically focused on primary care. So voila, 2 years later, we did what they asked for. And we wanted to emphasize simply on the diagnosis and management of hypertension in primary care and limit the number of recommendations. We didn't want hundreds of recommendations because we knew that primary care would not attend to hundreds of recommendations. So, Greg, I'm going to hang it over to you.
All right. So if you can unshare and then I will share my slides. All right, perfect. All right, are my slides coming through okay? Yeah, okay. So thanks, Jeff, for kind of discussing the background there. So I'm going to kind of walk you through a bit of the methodology and the actual recommendations and algorithms that we came up with. So like Jeff mentioned, we were trying to keep the number of recommendations to a fairly small number and kind of keep it to the basics of what's needed to manage most cases of hypertension in primary care. So we're able to kind of siphon that down to a total of 9 recommendations. And during this process, we used the ADAPT process, which is, it's basically a framework where, because we wanted to get these primary care guidelines out efficiently, we used existing evidence syntheses. So we looked at recent international guidelines, like such as the WHO, the ESC, the AHA, and we used their evidence syntheses to create our recommendations, kind of looking at these from the Canadian context. We looked at the strength of recommendation and certainty of evidence using GRADE, which has kind of become the standard for guideline development in terms of how to look at the existing evidence and how to rate the strength of those recommendations and the quality behind the evidence. With each recommendation, if you read the guideline in these journals where it was published, you'll see the scientific rationale and the evidence tables where we go through how we came to each of these recommendations. And specifically, we kind of outline the values and preferences that the committee took into account when we made each recommendation. And this wasn't just from the committee, it was actually from the public feedback as well, from other providers, as well as from our patient partners of the things, the pros and cons that they saw with each recommendation. And we tried to balance that and kind of give some discussion on how we came to each recommendation. And based on those 9 recommendations, we took those and then applied them to the HEARTS framework, with which Jeff spoke about, where we try to create these very pragmatic, streamlined algorithms, which once I show them to you, if you haven't seen them already, if you compare them to what was previously published in the 2020 guidelines, I think you'll see a big change in terms of the simplicity and how straightforward they are. So to talk a little bit about grade, this is how we kind of rank the strength of each recommendation and the certainty of evidence. So with each recommendation, you'll see a strength of recommendation being either strong or conditional. And you can kind of read between the lines with each recommendation, because if it's strong, it's something that we say is recommended. If it's conditional, we use the term suggested. And you can see the breakdown in terms of the certainty of evidence of high, moderate, low, very low. And it's basically just a way of saying how confident you are of the true effect size based on the existing literature. And so we provide this strength and certainty of the evidence with each recommendation we provide. So we broke our recommendations down into 2 categories. So one is diagnostic and the second is treatment. So I'll start with diagnostic first. So you can see our 3 diagnostic recommendations here. So our first, and these, at least the first 2 are not a real departure from what has been there historically. So the first is blood pressure assessment should be done with a validated automated device and using a standardized method, which is recommended. Second is we recommend that out-of-office blood pressure assessment be used to confirm the diagnosis of hypertension or to detect the phenotypes of white coat hypertension or masked hypertension. And one of the big changes in the recommendations is the definition of hypertension in the 3rd recommendation here. So we define hypertension in adults as greater than or equal to 130/80 when measured with a validated device under optimal conditions. And with each of these recommendations, the strength was strong for all 3. The certainty of evidence was moderate. And I will point out here, and I'll get more into it later, even though we define hypertension as 130/80, that doesn't mean everybody above that threshold needs to start medications. And I'll get more into that detail because I think that's something that there may be a little bit of confusion around, which I'll try to clarify here. So we're defining hypertension as that, but it doesn't mean everybody at that threshold or above that threshold needs medications. So one of the figures from our guideline is this, which kind of gives a straightforward example of optimal blood pressure measuring technique. And here we outline how the patient should be seated with their sitting position, back supported, where to place the cuff size that should be used, asking the patient to be quiet and not speaking there, have their feet flat on the floor, a quiet and calm room, things to avoid prior to the measurement, like exercise, smoking. You can see a QR code here, which is provided, which gives a link to validated automated devices that Hypertension Canada recommends for blood pressure measurement. And then we talk about the general standardized protocol in terms of a rest period, how often to measure the blood pressure, at what intervals, and to average the values. So this gives kind of a very kind of quick and easy to follow recommendation in terms of how to actually perform a blood pressure measurement. So going back to, if you think back to those slides that Jeff showed you earlier in terms of the prior diagnostic algorithm, if you compare that to where we are now, you can see it's much more streamlined and probably easier to remember and easier to follow. So starting at the top here, if you suspect somebody has hypertension, for whatever reason, it could be based on office, pharmacy, or home blood pressures. The next step would be office blood pressure assessment using a standardized approach like we just showed on the prior slide. And then again, the threshold we're looking for is greater than or equal to 130/80. Which if you're below that, we're going to say no hypertension. Now, if you're worried about masked hypertension, obviously you kind of want to delve further into that and do more testing. But if your blood pressure is over 130/80 in the office, then we recommend out-of-office assessment based on ABPM or home blood pressure monitoring. And if the mean daytime ABPM is over 130/80 or the home blood pressure monitor is over 130/80, we'll call it hypertension. If not, call it white coat hypertension. And when we label somebody as no hypertension or white coat hypertension here, it doesn't mean they're forgotten. You should still kind of see them at least on a yearly basis. And if they're seen in other offices, take advantage of those settings to measure their blood pressure and see if maybe they have switched over to hypertension. But this is kind of our streamlined algorithm in terms of diagnosis of hypertension. So some of the particularities regarding this diagnostic algorithm, we recommend a standardized technique using a validated device to be used to implement these recommendations. A non-standardized or oscillatory technique does not allow for sufficiently reliable and reproducible measurements. And in fact, they've been shown to overestimate blood pressure by 5 to 10 millimeters of mercury. We discussed this new threshold for defining hypertension in Canada as 130/80. Now, it's not actually that big of a change from prior recommendations with hypertension Canada, where if you look at 2020, the recommendation was 135/85. Now, obviously, more people in Canada will be labeled as having hypertension with this, and we approximate it's going to be about 9% more individuals will be labeled as having hypertension. Again, that's not necessarily saying all of those individuals need medications, and I'll show you that as we get to the treatment algorithms. We actually expect it to be about 1.5 or less percent that would actually need medications based on this that wouldn't already be treated today. And kind of a big emphasis from our primary care committee members was they wanted a single number to remember in terms of what is hypertension. And so that's why, based on the evidence, we chose 130/80 based on standardized blood pressure measurements. And this corresponds to the same cardiovascular risk as a blood pressure of 130/80 measured at home or with ABPM based on daytime numbers. Okay, so switching gears here, let's talk a bit about the treatment recommendations. So we have 6 treatment recommendations, and I'll walk through the first 3 here. So our first is healthy lifestyle changes are recommended for all adults with hypertension. And we don't, in the recommendation itself, we don't go into each specific lifestyle change. We do talk about them in the text, but I'll kind of get through I'll go through some of the different lifestyle changes that we talk about in the guideline. The second recommendation here is pharmacotherapy initiation for hypertension is recommended for all adults with blood pressure over 140/90. Again, this is a departure from what was previously where low risk was 160 based on the 2020 guidelines. So now we're saying blood pressure over 140/90 for all adults. But for those who have a systolic blood pressure of 130 to 139 and are at high cardiovascular disease risk, we recommend starting pharmacotherapy for them as well. And I'll go through some of this evidence. The third recommendation here is treatment, including healthy lifestyle changes with or without pharmacotherapy, is recommended for all adults with hypertension, and the target systolic blood pressure is less than 130, provided the treatment is well tolerated. And the strength of recommendations for all of these is strong, and the certainty of evidence is high for each of these. And I'll go through some of the background on why we came to each of these recommendations. So in terms of healthy lifestyle habits with that first recommendation I just showed you, we go through several of these here. So those, I think we all know these, of decreased sodium intake, increasing potassium intake, achieving a healthy weight, regular exercise, particularly aerobic activity, limiting alcohol take, and stopping tobacco products. We didn't give each of one of these their individual recommendations because we really think this should be kind of tailored on a case-by-case basis, because certainly some of these may be more applicable to them than others. Not all of them drink alcohol. Maybe some of them need to focus more on exercise or stopping tobacco. And you can kind of tailor this to your own patient and what lifestyle modifications would be most beneficial for them and what might be most reasonable for them to actually implement in their day-to-day lives. And when we talk about, again, we have different thresholds for when to initiate medication based on whether someone's at high cardiovascular risk or not. And so in terms of how do we define high cardiovascular risk, this is the list that we put forward. And this is based on not only the ESC guidelines, which were recently released, but also the SPRINT criteria. So we label high cardiovascular disease risk as established cardiovascular disease. So patients with coronary disease, heart failure, stroke, peripheral arterial disease. I think we would all agree that those patients are high cardiovascular risk. Diabetes, both type 1 and type 2. Individuals with CKD, and you can see the eGFR and albuminuria thresholds there. The Framingham risk score of over 20%, and age over 75 as well. So that's what we're going to label as high cardiovascular risk. So So obviously we're recommending that we target a systolic blood pressure of less than 130. And what's the evidence to support this? Because this is a big update from 2020. Well, this is a recent meta-analysis that was presented where they looked at a number of these interventional trials on more intensive blood pressure targets and looked at the risk for both cardiovascular events and mortality. So you can see a lot of these studies I'm sure you're familiar with. So you see SPRINT there, you see ACCORD, you see STEP. And if you look at, and these are looking at less than 130 versus over 130. And you can see on the left there in terms of cardiovascular events, it's pretty universal that with the less than 130 target, you reduce cardiovascular events, and it's about a 22% lower risk, so pretty substantial. On the right, if you look at the meta-analysis in terms of mortality, and this is all-cause mortality, you see that with a less than 130 target, so the more intensive target, you end up reducing mortality by about 11%. So 11% lower risk. So a big, big change with targeting with more intensive blood pressure lowering. So, and if you look at the less than 130 target, if you look at the top part of this table, you can see this is true for all the different cardiovascular outcomes we would be interested in. So if you look at stroke, coronary heart disease, heart failure, cardiovascular mortality, they're all substantially reduced with this more intensive blood pressure lowering. As you can see, the hazard ratios there are from 0.69, so over 30% lower risk for heart failure to 27% lower risk for cardiovascular mortality. So there's a lot of data to support this lower blood pressure target. Now, one question that often comes up is with more intensive blood pressure lowering, what are the potential harms to a patient? And so this meta-analysis also took into account adverse events with more intensive blood pressure lowering. And so you can see some of the common ones that I think everybody here would think of, so in terms of hypotension, syncope, injurious falls, electrolyte abnormalities, AKI, and acute renal failure. Sure, these do happen, but if you look at the number needed to harm there, it's quite high for all of these. So the lowest is hypotension at 508. So you'd have to treat 508 patients before you had one that developed hypotension. But even some of these are well over 1,000 and electrolyte abnormalities over 3,000. So you would have to treat a lot of patients to get one that you would be harmed by this more intensive blood pressure lowering target. All that being said is the adverse event rate is quite low with more intensive blood pressure lowering. So really the balance of evidence really favors the benefits over the potential risks of this more intensive target in terms of blood pressure lowering. All right, so those were the first three recommendations. So this is our next two treatment recommendations as well. So we say that for adults with hypertension requiring pharmacotherapy, low-dose combination therapy, and I'll emphasize ideally as a single pill combination, so 2 drugs in 1 pill, is recommended as initial treatment, which include drugs from 2 of the following 3 complementary classes of medications. So ACEs or ARBs, thiazides or thiazide-like diuretics, and long-acting dihydropyridine calcium channel blockers. And then the next recommendation is if blood pressure remains above target despite the true drug combination, 3-drug combination therapy consisting of an ACE or an ARB, a thiazide or thiazide-like diuretic, and a long-acting dihydropyridine calcium channel blocker is recommended. So both of those we ranked as having strong recommendations with moderate certainty evidence. So many of you may have heard the discussion last week at the Hypertension Congress about the benefits of combination therapy, which is really over recent years has really gotten a lot of publicity and a lot of support behind it based on the evidence. So it turns out that when you look at patients that are treated for hypertension, 70% generally will need more than 1 drug anyway. So the majority of patients with hypertension are going to need more than 1 class of drug regardless. When you use initial upfront combination therapy, you get an overall 4 millimeter reduction in blood pressure versus using 2 separate agents. The other benefits, 32% more patients will have controlled hypertension when you start with a combo pill. And interestingly, you actually can often get a lower risk for side effects because what happens with these combo pills is you can use the combo at lower doses than you would generally use for each of the individual agents. And with the combo pills at the lower doses, you can actually often have a lower risk for side effects. There's good evidence that patients are more adherent to combination pills, and the persistence of treatment is also higher, meaning that they remain adherent for a longer period of time. There's evidence that starting with combo pills lowers the risk for hospitalization, cardiovascular events, and death. There's economic benefits, which I'll go into more detail in a few slides here. And there's no increase in the risk of discontinuation compared to individual agents or monotherapy. So there's a lot of data supporting combination therapy. And the final treatment recommendation here is if blood pressure remains above target despite 3-drug combination therapy consisting of an ACE or ARB, thiazide or thiazide-like diuretic, and a long-acting dihydropyridine calcium channel blocker. At their maximally tolerated doses, the addition of spironolactone is suggested. Now, the strength of this recommendation is conditional, and the certainty of evidence we ranked as moderate. So some of the particularities here regarding some of our treatment recommendations. So as Jeff mentioned earlier, these are not recommended. They're not intended for everyone. So they're not intended for the treatment of people who are pregnant, planning to become pregnant, those who are breastfeeding, or children. We do suggest that all individuals with hypertension should be treated. Now, that doesn't necessarily mean treatment with medications. Some are treated with just emphasizing lifestyle modification. So, and again, as I mentioned, a large proportion of this new hypertension population would only be treated with non-pharmacologic therapy. So it would be lifestyle modification. So that's one thing to emphasize here. We have an identical treatment target for all patients. And this was really a push from primary care to give kind of a single definition for hypertension and a single treatment target. But the level of blood pressure in the presence of cardiovascular risk factors determines the threshold for when we start medications. I will emphasize, though, that individualization of treatment remains important. So this is just a guideline. It doesn't mean how you manage every single patient. You have to take a number of things into consideration on a case-by-case basis, just like you do with any situation in clinical practice. So you have to consider the goals of care, how frail a patient is, what the risk of falling is, if they're predisposed to orthostatic hypotension. Obviously, you need to take those into account. And in those situations, we suggest aiming for as low as a blood pressure as possible if the target cannot be achieved. And certainly, SPRINT and some other studies kind of recommend the possibility of aiming for systolic blood pressure of less than 120 in people who are at very high cardiovascular risk. And we discussed this in the guideline that certainly you can target lower in patients that are very high cardiovascular risk. And so I think that's something that still needs to be, you have to use your discretion on which of the patients would benefit most from more, even greater intensity in terms of blood pressure lowering. So thiazide diuretics like hydrochlorothiazide and thiazide-type diuretics like chlorthalidone or indapamide are considered, in our guideline, considered equivalent from the point of view of antihypertensive effect and cardiovascular protection. This is a bit of a change from prior, and this is based on the results of a large RCT that was published in the New England Journal last year, which really showed no difference in terms of outcomes when using HCTZ versus a thiazide-type diuretic. However, the committee did believe that agents with a longer duration of action should be given priority as far as possible. Now, you'll see when we kind of go through the different combination pills that are available, the ones with thiazide-type diuretics are very limited. So we did choose one with, in terms of our leading candidate for combination pill was one with HCTZ, but just based on availability of which combo pills are currently available in a generic form in Canada. We no longer recommend beta blockers in the absence of specific indications. So certainly beta blockers you'll still want when there's a specific indications like heart failure or post-MI or arrhythmias. But outside of that context, we don't recommend them in the absence of one of those recommendations. And kind of one thing that a lot of people have noted is the absence of a diastolic blood pressure target, as we list a systolic target, but not a diastolic target. And this is because the benefits of reducing diastolic blood pressure when the systolic pressure is less than 130 is very uncertain. So this isolated diastolic hypertension, in terms of treating it, as long as you get the systolic less than 130, there's not great evidence to support targeting just the diastolic number. So if you think back to the treatment algorithm that Jeff had shown earlier, this is a big departure again, and trying to kind of keep things simplified, pragmatic, and streamlined in regard to the Hart's algorithms and the Hart's framework. So that's really how we derive these. So this is our treatment algorithm. So I'll walk you through it here. So if you look at the top, so we have somebody where we diagnose hypertension. So we establish this diagnosis of a blood pressure greater than or equal to 130 with out-of-office confirmation. And again, we're targeting a systolic pressure less than 130 using standardized blood pressure measurements. So say in that situation, if your blood pressure is greater than 140/90, or your systolic's 130 to 139, and you're at high cardiovascular risk based on those conditions we spoke about earlier, we recommend both lifestyle changes, but also pharmacotherapy. And I'll ask you to ignore this gray box at the moment, and I'll come back to it here. So we recommend lifestyle changes and medications if you fit this 140/90 or systolic 130 to 139 and high cardiovascular risk. Now, if your systolic is 130 to 139 and you don't have one of those high cardiovascular risk conditions, we suggest emphasizing healthy lifestyle changes and then reassessing in 3 to 6 months. If you're still in the same boat where you're 130 to 139 and not high cardiovascular risk, you keep emphasizing healthy lifestyle changes and continuously reassess every 6 to 12 months. But if over that reassessment time, if you kind of switch over here, where now you're 140 over 90, or you develop high cardiovascular risk conditions, that's when you go to this group on the left here, where we talk about healthy lifestyle changes and pharmacotherapy. And in terms of that stepwise approach to medications and pharmacotherapy, we chose, Hearts really suggest that specifying certain medications that are available that are in your country that are efficacious, affordable, and in that there's no real kind of issues with supply. And so that's how we ended up going, and I'll show you a little bit more data on this of why we chose the combo pill we did. But we recommend starting step one is a combination pill of irbesartan HCTZ, which can be a half tablet of the 325 dose. So it'd be 150, 12.5 milligrams daily. And that can either be as a 150, 12.5 pill of its own, or half a pill of the 325 version. So that's irbesartan HCTZ. Step two would be going to the full dose. So irbesartan HCTZ 325 would be step two. Step three would be adding amlodipine, which you can start at 5 milligrams daily and up titrate to 10 if needed. And step four is adding spironolactone, which can be started at 12.5 and up titrated to 25 milligrams daily, or referral to a specialist, or both. And between these steps, we recommend assessing every 1 to 3 months until blood pressure is at target, and then ideally every 6 to 12 months thereafter. And along this pathway, if you have any concerns for secondary hypertension, like there's clinical clues that you think some secondary cause is there, or if you reach step four here and you're still uncontrolled, we do recommend a referral to a hypertension specialist, especially when there's concerns for secondary causes. So again, we recommend irbesartan HCTZ here, but that's not saying you have to choose that. There's a number of combination pills that are available in Canada, and here we kind of list them and what's available and the different prices. So we were looking for a combination pill that was, since this will be population-wide, one that's cheaper. So obviously irbesartan HCTZ is on the very lower end here. And we also wanted one with less side effects, which is why we recommended an ARB over an ACE inhibitor up front. And also we wanted one that had multiple generic manufacturers, because we didn't want to run into the issue where there's back order problems or supply problems. And that's really how we landed on irbesartan HCTZ. We did consider telmisartan HCTZ, but there were some issues with the dose and being able to kind of split the tablet, which is how we landed on irbesartan HCTZ here. But that's not to say that has to be the choice. If you really prefer a different agent, we outline all the different options here. Many have asked why we didn't use telmisartan amlodipine, but you can see the price is over double, which when you think about population-wide, that could be kind of a big factor in how we landed on the one that we did. Again, you're not tied to that though. And again, using this sort of standardized treatment algorithm has proven benefit. And Jeff talked to you about Hearts. And again, this started in Kaiser Permanente in the US, where if you look from 2004 to 2010 using a similar approach, they got their control rates way up. So they went 54% up to 84%. So a huge, huge benefit. Data beyond this actually shows they go above 90% control. And there was a meta-analysis on terms of standardized treatment algorithms in terms of their effectiveness that was published last year. And it showed that these kind of standardized approaches proved to have beneficial effects in terms of blood pressure lowering. So using a standardized approach, if you look across all these different studies, the average systolic blood pressure decrease was about 7 millimeters of mercury, and diastolic blood pressure was about 3 millimeters mercury. So these standardized treatment algorithms really do work in improving population-wide blood pressure control. And some other advantages of a standardized treatment algorithm, you can have both purchasing and cost reduction when you do have these standardized approaches. And it standardizes care. And it really does facilitate education initiatives on kind of creating these simplified, streamlined algorithms that can be easily implemented into day-to-day practice. So the big focus today was on our primary care guidelines, because we're very excited to launch those and hear your feedback. I will share some other aspects that we are working on as well. So concurrent with these these primary care guidelines, we also released this patient or public facing, we call it guidelines, but it's really a kind of a patient support tool that we created. So we had a group of patient partners that worked with us throughout the guideline development process. And they not only kind of weighed in on our primary care guidelines, they actually took the steps to actually create their own guidelines, which kind of translates what we had put forward into terminology that would be very easy to comprehend for the public and for patients. And so this was created for and by our patient partners. It focuses on topics that are important to patients where they can take action. So we can have them engaged in kind of managing their hypertension and see what they can do themselves to help improve their care. And it really helps to make them to make the decisions that are beneficial. And they can be actively involved. So this is the cover of the patient-facing guidelines for the French version. And I'll show you what a few of the pages look like. So this is some of the pages that are inside this patient support tool or these patient-facing guidelines. So one of the pages was, how can I maintain a healthy blood pressure? And it goes through kind of simple, short sentences with kind of things that they can do in terms of eating a healthy diet, reducing salt intake, exercise, reducing alcohol use. And it kind of breaks it down very simply. And then we go through things like some of the common questions that our patient partners thought would come up frequently from patients of, do I have high blood pressure? And again, this translates what we say in our primary care guidelines to answer patient questions. Should I measure my blood pressure at home? What should I do before I go to clinic? Do I need to take my pills? And what blood pressure should I try to be? What's a sign of success? Like what number should I be trying to reach? So this kind of helps address some of those questions so that when they come to your office, they may already have some of their questions answered, but they may be more informed of what they'll ask you and kind of know what to expect in the office. So Jeff had mentioned that this primary care guideline is just the first step in our guideline process. So we're taking a bit of a different approach than has historically been done with Hypertension Canada, where the group would meet every year or two and do this one kind of comprehensive guideline all at once. Again, we wanted to focus on primary care up front because we thought that was going to be where the most bang for our buck would be in terms of getting hypertension control rates improved. As Jeff showed, they've been declining over recent years in Canada. So we're trying to kind of reverse that trend. But we do still see, obviously, there's huge value in these comprehensive guidelines, and we're taking a bit of a different approach now. So rather than launching everything at once, we think a new approach would be to do this on kind of a rolling basis, where we choose a handful of topics each year, where there really is new and emerging and kind of groundbreaking evidence that will change practice, and focus on those guidelines each year and emphasize. And so it'll be kind of done on a rolling basis where Living on the Hypertension Canada website and an app will update each of these topics, whether those topics be pediatric hypertension, secondary forms of hypertension like primary aldosteronism, or hypertension in chronic kidney disease or in the elderly. We'll tackle each of these topics kind of on a one-by-one basis, and we plan to do a handful of topics each year. And we're obviously going to reach out to a lot of you to be involved with these. And the first step is really this prioritization exercise where we want to know which topics in terms of these comprehensive guidelines would be of most interest to our community. So I do have the QR codes here to share with you in both the English and French versions, which will take you to this survey in terms of getting a sense from you of which topics you think are most in need of being updated and which we should focus on first for these rolling hypertension comprehensive guidelines. And just so you know that we're going to be doing knowledge syntheses for each of these different topics. And we're doing this actually in conjunction with Hypertension Australia. So we're kind of going to combine our forces here to make it as efficient as possible and share on cost as well. So if we come up with similar priorities in terms of when you do these prioritization exercises, they're actually doing it concurrently right now as well. And where we see overlap here, we're actually going to combine our forces to work with them to create these comprehensive guidelines on a topic by topic basis. So as many of you, if any of you are interested, please go ahead and use those QR codes to fill out these surveys for us. That would be very appreciated. So I'll finish with this of some of the key messages that I think are some take homes from our primary care guidelines. So this is really only the first step of this new guideline process. We're moving forward with the comprehensive guidelines, and we're hoping many of you will be involved in that process. We think the importance of optimal blood pressure measurement is key because without accurate measurement, it's hard to know how to manage a patient. New hypertension diagnosis threshold is 130/80 for all. We recommend treating everyone, but some only with non-pharmacologic measures. So if blood pressure is over 140/90 or systolic blood pressure 130 to 139 and the patient's at high cardiovascular risk, start pharmacotherapy without waiting for the effects of non-pharma measures, but still do those lifestyle modifications, but in conjunction with pharmacotherapy. We now recommend low-dose combination therapy as first-line treatment, and we recommend spironolactone as a fourth-line agent. So I would like to say a special thank you to our primary care guideline committee, including Jeff, as well as a number of other primary care providers, pharmacists, nurses, hypertension specialists. It was really a great group to work with, as well as our patient partners as well, played a huge role in this, especially creating the patient support tool and this public-facing guideline as well. Many of you provided feedback during the public review phase, which we really do appreciate your help and your input, and actually made a number of changes based on that feedback. And that included a number of patient partners as well during this external review as well. And so we really like to thank all of those people. And with that, I'll pause and we'd be happy to take any questions.
There's some great questions that come up again and again, Greg, about ABPM. We used to talk before about daytime and nighttime averages. So what do we do now with ABPM?
Yeah, so I think ABPM is still important. And so one of the best ways of kind of clarifying somebody's home blood pressure is doing daytime or doing ABPM. And so the numbers that we gave there were based on daytime ABPM. Now, some of the questions that have come up are in terms of nocturnal hypertension. When you if you get isolated nocturnal hypertension, certainly that's a cardiovascular risk factor. The evidence behind targeting it is a little bit different. It's not that clear. Certainly it's a risk factor, but how we intervene on that can be a bit different. It may change how you might affect timing of medication administration and some other things you might look for in terms of sleep apnea and other things. That is one of the topics that we're probably going to go into more detail on when we get to these comprehensive guidelines. So it still has a big role. And so that's kind of how I would address it. It's still something that ABPM we still think is very important, especially for kind of verifying the diagnosis of hypertension, because I think you all know that we get a ton of white coat hypertension, and you probably pick up a lot of masked hypertension this way too. Right. So I still think it plays a big role.
We talk a great question actually, and we'll clarify. We talk about 130/80. Is it the 130 or is it the 80? And that's a great question.
Yeah, so when we label when we're labeling hypertension, we're 130 or it's 130 or 80. It's like you can base it off either. Now again, the target in terms of shooting for targets, we isolate the systolic blood pressure. That's really where these trials have the evidence, is targeting the systolic blood pressure. If you look at most people that achieve less than 130, most of them their diastolic's under 80, but those that say their systolic's under 130 and their diastolic's still above in the 80s, there's not really evidence that those individuals are at higher cardiovascular risk. So
Right.
that's why
So the
we really focus on.
128/94.
Yeah, there's not great evidence that those individuals are at higher risk than somebody that, as long as their systolic blood pressure is 130, that's really where the proof is and the existing evidence. And that's where all these trials have really focused on.
And in our diagnostic slide, we say 130/80. But the question is that office, is that home, or does it matter?
For diagnosis?
Yeah.
Yeah, so for diagnosis, we do think that home kind of confirming the diagnosis at home is key, because you do want to rule out these white coat hypertension cases, because you do look at managing them differently, I should say. So we do think it's necessary to do, if you can. We realize there's sometimes where you don't necessarily have the availability of ABPM or home blood pressure monitoring in certain cases, in which case you may be reliant on office readings alone. But I do think it's very important, and we state this as a strong recommendation in terms of verifying that 130/80 in the office with home blood pressure assessments.
And this is a question that me and you have actually talked about a couple of times. Why did we move away from 120 in sprint? And if we target 130, aren't you worried about people will say 135 is enough? That's the same with every guideline when you pick a number. But why do we move away from 120?
Yeah, so I wouldn't say we're moving away from 120, and I do think some people that are very high cardiovascular risk, you can certainly target less than 120. Now, there's a couple reasons we didn't put 120 as the overall target as in terms of putting one number down as a target. And some of those reasons are, if you actually look at Sprint, though they were targeting 120, most of them actually didn't get under that. Most of them were in the 120 to 130 range. So it's what they were targeting, but they didn't necessarily achieve. Other reasons is if you look at Sprint, these are research quality blood pressure measurements they're getting. So this is very well conducted, like perfect blood pressure assessments. And when you compare them to real world clinic blood pressure readings, there's very strong evidence that the blood pressure that we get in research settings is 5 to 10 millimeters of mercury lower than what you get in clinical practice. So kind of giving a little bit of that buffer zone, I think it makes sense. And that's why we put 130 rather than 120 to kind of account for this real world situation and what was actually achieved in sprint. And Jeff, I think you kind of had some similar outlook in terms of that as well.
Yeah, I mean, it's similar. I mean, we see in sprint that, I mean, I looked at it because of our discussion. I mean, they achieved 121.5 and the placebo group achieved 136, which is a lot higher than we said. So if you look at the meta-analysis, all of them, including sprint, it's important. The other thing to realize, sprint excluded diabetics and sprint excluded all those low risk patients. So your 58-year-old hypertensive with no risk was not in sprint. So that's where these guidelines came from. All right, another great question. Just to explain again, this flip-flop with hydrochlorothiazide and chlorothalidone and indapamide. What do you think?
Yeah, so it's a bigger debate, and even amongst our committee, I think it was pretty
Yeah, it
contentious
was.
on how people felt. So certainly, there's several people that felt strongly that we should be going for the longer-acting thiazide-like diuretics like clothianidin and indapamide. And I certainly can understand the reason. Now, this New England Journal study from a year or so ago showed that in terms of cardiovascular events, there was really no difference with hydrochlorothiazide versus chlorthalidone. And the only real difference they found was a higher risk for hypokalemia with chlorthalidone. Um, that being said, we're also a bit limited in terms of when we do feel like the evidence for combo pills is very strong. And the combo pills that I showed you on that slide earlier are kind of the options are limited. There's actually not many with indapamide or chlorthalidone in them. Um, we do kind of look at these hearts algorithms are supposed to be updated in the future based on kind of what availability is. And so we've actually reached out to generic manufacturers saying that, yeah, if you can produce one of these combo pills where you include indapamide or chlorthalidone at a cheap cost over hydrochlorothiazide, we do think that would be something we would very much consider moving in that direction in the future. That's not really there right now. And so we felt the best option right now was hydrochlorothiazide. But again, it's a bit of a contentious area because the evidence may not really be there in terms of lowering cardiovascular risk, at least to this point. But we do see the benefits in kind of longer acting therapies. And if that option becomes available in a combo pill in the future, I think we really will need to consider it.
Would you consider people with obesity or let's say BMIs over 40 a CV risk factor for a treatment target to start treating at 130, over 130?
Yeah, that's a really good question. And so I think that's one where you have to use your clinical discretion. I certainly would think about somebody like that personally. If I saw that person in practice, that is probably somebody I would think about being in the higher risk group and treating them more aggressively. And I know, Jeff,
I
if you
agree.
feel the same way.
I agree totally. Like, I think we need to consider our patients with obesity as a risk factor, and I would start treating them at BB. And I mean, we've seen the increased mortality in our persons with obesity, so I think that's very important. Two very specific medication questions. We didn't include perindopril amlodipine on the list, I think, because of cost, correct?
Correct. Yeah.
Okay, that's a question that comes up. The other one is spironolactone. If you're going to use it fourth line, what dose and what do you do? And what do you do about the side effects?
Yeah. So very good question. So there is good data in terms of like the Pathway 2 study where it was very unclear in the past of what was the best fourth line agent. Was it beta blockers, alpha blockers? And so Pathway 2 did show that it had the spironolactone was far superior in terms of blood pressure lowering those in those groups. That recommendation you will notice was conditional, and that's because even though we know it lowers blood pressure more for most of these individuals with resistant hypertension, we don't have proof yet that it actually lowers cardiovascular events in those individuals. That's why we made it conditional. Now, we recommend starting at generally a low dose. So 12.5 or 25 milligrams is what we say on our algorithm. Um, One thing I would also emphasize is that we realize more and more that primary aldosteronism is very common in patients with resistant hypertension. So we would suggest screening with aldosterone and renin prior to starting the spironolactone, and we mentioned that in the guideline as well. Now, the potential side effects obviously are there with spironolactone. So obviously, the one we think of most is some of the anti-androgen effects, particularly in men, where they'll develop gynecomastia or breast tenderness or something like that. And also in chronic kidney disease, you worry about hyperkalemia and things like that. So certainly those are there. They're usually dose dependent. So this is kind of starting on the lower end of spironolactone, but it is there. One thing I will mention, which this study came out after we actually had the guidelines accepted, was there was a recent study that compared amiloride versus spironolactone in this sort of scenario as well in terms of resistant hypertension, and it showed very similar blood pressure lowering effects with amiloride and spironolactone. So I think you can, and we may see where the guidelines head in the future, but that would be, if you're thinking of an alternative to spironolactone, if somebody does develop those side effects, amiloride might be another reasonable option to consider without
I
those
mean,
anti-androgen effects.
the other confusing thing for us is if you're going to measure aldosterone or renin levels, do you not have to stop ACE-ARB for 2 weeks prior?
Yeah, so I do a lot of work in this area on the aldosterone issue, and so generally no. So for patients who truly have primary aldosteronism, they have very low suppressed levels of angiotensin 2 and ACE. So usually the ACE inhibitors and ARBs don't have that much effect on those levels when their Ang2 levels and their ACE levels are very low. It's somebody like that. It's actually very hard to stop all their medications
Yeah,
just
that's
to
what I mean. It's really hard.
yeah. So I generally think of the medications that really interfere with aldo and renin measurements are MR antagonists like spironolactone, ENaC inhibitors like amiloride. And those are the two that are likely to give you false negatives. So if I were to think of medications that I would stop before I do aldo and renin screening,
It'd be only those two.
it'd be those two. And because otherwise, taking these patients that are on 4 or 5 blood pressure medications to screen for that can be dangerous in and of itself.
I mean, we have so many great questions, and we only have a minute left. So I'm going to ask this one because I think it applies to a large group. What about our elderly population, those over 80, those over 75? What do we think?
Yeah, that's a really good question because for one, they're high cardiovascular risk, right? Because we know from Sprint that the older you are, the higher you are at risk for cardiovascular events. That being said, this is where the guidelines don't replace clinical discretion and nuanced decision making because I think you have to look at that patient, and not every 80-year-old is the same. Some are fairly robust, some are more frail, and it kind of depends on their goals of care and what their risk for orthostatic hypotension is. So in those scenarios, I think you still have to, it's hard to give one blanket statement of how do you handle that patient population. It's really on a case by case basis. And we recommend targeting the lowest tolerated blood pressure if you can't achieve those targets, where you get to the lowest blood pressure target that they can tolerate and function day to day. But I do think you have to, when you get to those sort of populations, do you have to factor that in? I assume you have the kind of a similar experience as well.
Exactly. And when we talk about lowest tolerable blood pressure, we don't want our patients feeling faint or fainting. But remember, if you look at all the data, lower is better. And we picked 130 because if you look at the evidence, under 130 was effective and it balanced the pros and the cons. But lower is always better, as we mentioned in the guidelines. The higher risk patients, if you can get to 120 safely, then you should do it. Okay, last question. Uh, Angioedema with an ACE, you go to ARB. What about angioedema with an ARB?
Oh, so you don't see that very often. But if you're in that scenario, obviously anything with angioedema, you're probably out of those both of those categories anyway and onto your other options. And that when you might be thinking of some of those, that rare patient that would have angioedema from an ARB, that's when you're kind of into, obviously you probably want to focus on different
Yeah,
blood pressure
like
classes at that point.
amlodipine and
Yeah,
diuretic. All right,
exactly.
Greg, thank you. This was great. There is so much interest, and it's very exciting for us, and we hope this really helps all of our colleagues. So thank you very much for being a leader on this. It was a lot of fun, and thank you for today.
Yeah, thank you so much.
Have a good day, everybody.